Now go on to Dr. SATANSHU Mathur, who's the medical director of High Tech Institute and Laser Center at Kashipur, and a very popular, in the national stage, and he's an extremely friendly and a very versatile, prolific surgeon. And let us hear from him. He's taken on a tough topic: black cataract and low endothelial cell count, my approach. On to you, Dr. SATANSHU. Wonderful.
So, Dr. Chitra and Dr. Satyajit, thanks a lot for ARC. AIS, my topic is given as my MSIC is in heart cataract. I am fond of doing SICS surgeries, and Dr. Kamalji, Dr. Ravindra, all are here, master of SICS surgeries. SICS surgery is especially important in heart cataract. Why? Everybody do not have the advanced machines. Everybody do not have the masterized the surgery of the phaco. So SICS is safe in hands of the surgeon who is not very competent, even in case of not very advanced machines. You can give many types of incision, smile incision, straight incision, prawn. It depends upon your choice. But for the newcomers, the straight incision and the big incision is very important in heart cataract. Second important thing after incision is the rhexis. Recommended capsule rhexis is 6 mm. In 90% cases, it is successful. So I am giving the straight incision almost. It is big incision in heart cataract, especially for the younger surgeon. And you should make a tunnel not less than 6 mm. It can be 6.5 mm, but not less than 6 mm in heart cataract. Heart means it is black-brown cataract. So once you have completed the incision, you have to check the incision is perfect. If you can make a side port. And staining is very important in heart cataract because we do not want rhexis to be extended. So after staining the capsular rhexis done, it should be not less than 6 mm in heart cataract. It should be complete CCC, is it better and safe. In heart cataract, you sometimes feel difficulty because of the shallow chamber. So you keep injecting viscoelastic regularly from the side port. Now incision is extended 6 mm outside, and in the side pocket have been made. So inside incision is almost 7 mm, outside is 6 mm. Now copious amount of fluid is injected on behind the rhexis on one side, then on the other side. That will push the nucleus out on one side. So nucleus has come out on the one side. Now again inject viscoelastic and rotate the nucleus by 2 dialer to bring it outside the bag into the anterior chamber. Once the nucleus is anterior chamber, you can take it out by many means, by vectis, by fish hook. In this case, we are taking it out by irrigating vectis. Irrigating vectis, when it goes inside, it is irrigation is off. When it comes into wound area, irrigation starts. You can say this is black cataract, very hard cataract. So even when the cornea is compromised, by this technique, you can have a better cornea next day in comparison to the phaco. You can implant the PMM lens, you can implant the foldable lens. This is the CAM surgery. So we are implanting the non-foldable lens. You will have a better cornea next day, even in compromised corneas where the endothelium is not very healthy. So you can see even 6 mm incision is self-healing. We do not have to put any stitch in it. This is another case where we have straight incision and we have extended it vertically up. This is only 5 mm incision, but it is extended vertically, you can see. So it has become 6 mm outside, but it will produce less astigmatism. Its extension is in vertical direction. they in this you can see we are this is special cannula. You can see this is a curve. On this curve, nucleus rests and it comes out easily. And we keep injecting viscoelastic through this cannula. It is 18 gauge cannula. It has a curved structure. On the curvature of this cannula rests the nucleus and it comes out. You can see the hard cataract, it has come out. This is the hardest cataract you can see. So we can implant a foldable lens in this and we can achieve the good success rate. So thank you very much, Dr. Chitra.
Yeah. Wonderful videos, Dr. Satanshu. You showed very well and gave us all the relevant tips of dealing with it. And you have not thought of doing a nucleus fracture, but remove the nucleus end to in all these kinds of cataracts and by enlarging the internal lip of the incision. One question, in case of a situation of a persistent corneal edema, which could be seen in some case, not in, then what would you look for in these cases? Doctor, anybody on the expert panel? Dr. Meghur? Dr. Ravindra?
Yeah, decimus detachment is one thing that you'll have to see many times because of edema, you may not notice it. But you can do an OCT and find it out in that meridian.
Yeah. Anything else, Dr. Sarkar?
Yes, ma'am. Most of the time, actually, what happens, this type of cataract, sometimes patient, the primary surgeon thought the edema will goes by hypocell 5 or hypocell 6. If you have doubt or something, better to whatever sir addressed, do a simple ASOCT. And in the early stage, if you detect any, if there is a DMD is there, and simply air injection or C3 of it, simply make a hairline scar and make your job very easy. Patient will be happy. And if it is persistent going on, and ultimately, if the fish mouthing is there and there is persistent macular edema, there is a corneal edema will be there, then you landed up with the PBK. So if you have a doubt for, then rule out the DMD, and if it is addressed properly, then we can just avoid the further PBK like complications.
Thank you.